Okay, so I'm going to talk to you about Safewards. If you don't know what Safewards is, I will explain as we go along. But just 11 years ago now, Safewards was launched into the world by my good friend, colleague and mentor, Len Bowers, and I'll be telling you about that. I'll be telling you about how it's developed. There's been lots more research and implementation of Safewards. Some of the challenges and where we may be going over the next 10 years or so. So, welcome, hi, from London. Top picture there, houses apartment, you'll see a classic picture of London. On the right-hand side is Rye Lane in Peckham, near where we live, my partner and I, who's down here. And yeah, a slightly different view of London. And that's our street where we live, just to give you a little picture of what our life is like. And I also just want to give a big up to Burnham-on-Sea. Burnham-on-Sea is a small little seaside town where I was born and raised. As you can see, it's got a lovely beach, 7 miles of golden sand. And it has the only 9-legged lighthouse in the world on the beach. So well worth a visit if you fancy a nice trip to England. Burnham-on-Sea, don't forget. Okay, 10 years. A lot has happened in 10 years. Our former leader of many years, Margaret Thatcher, Prime Minister, died. Since then, amongst others, we've had far, far too many Prime Ministers. Most of them, unfortunately, Conservative Prime Ministers in a very short period of time. And we're currently trying to decide who our next Prime Minister is going to be. And we're hoping some more positive news. More positively, there's been many social changes, one of which has been the recognition now of same-sex marriage in the UK. It's taken a while, but we've got there, and it's good to see. I know Finland were well ahead in that game a long time ago. There's been all sorts of things going on with the royal family, which you may or may not be aware of. And very, very sadly, we voted to leave Brexit, which most of us in the country really regret, didn't want in the first place. And it's been a huge, huge wound, self-imposed wound. So we can only apologise, and hopefully over the years we can rebuild our relationships with our European Scandinavian partners. Chelsea, my team, won the European Champions League for the 2nd time. Yay. And Finland have joined NATO. I assume that's a good thing, but we shall see. Okay, so lots has gone on. So in Thursday, the 5th of September 2013, there was a network of psychiatric nursing research conference held in Oxford. And my old boss, Len Bowers, presented the results of a trial of Safewards. My good friend and colleague Ben Hannigan wrote a blog about it, and he wrote this. Len Bowers used his Thursday keynote to share, for the first time anywhere, results from his Safewards trial. Len is a genuinely world-leading researcher, and Safewards is a big and important study with seriously major implications for policy, services, education, and practice. Take note, inpatient mental health nurses, the findings from this one are coming your way. And Ben was absolutely right. The impact of Safewards has been enormous, as I'm going to show you, and it's waved across the world, which way beyond anything we expected. So there's Len at the top, and underneath that is my good friend and colleague, Jeff Brennan, who I work with now. We do lots of work on Safewards still. My colleague, Jeff, very, very kindly put a lot of these slides together, and we talked about this presentation together. And he labelled Len as the dad of Safewards, and he labelled me as the stepdad, which I thought was rather sweet. So I said to him, I think you're the uncle. And he said, that sounded a little bit weird, a little bit pervy. So I said, how about kind uncle? He said, yeah, okay then. So Jeff has done loads of work. He and I were involved in the initial trial of Safewards, and Jeff has been at the forefront of supporting people to implement Safewards in the UK, in Ireland, across Europe, and in many other countries. And at the moment, we're working together with colleagues in China, and I'll say more about that later. So yeah, Jeff's still very much involved. He and I still manage the Safewards website, and Jeff's in charge of all the social media, the Facebook group, and all the rest of that. So if you're wondering who Jeff Brennan is, that's who he is. He's a good man. And Jeff also labelled this as the mums, the people who have been out there delivering safe wards in our inpatient wards and other settings across the world, across countries. And we really want to praise and thank and appreciate the enormous work that people do every day in our inpatient mental health wards. It's not easy work, not everybody can do it, but there are many, many thousands of people out there doing fantastic work. And Safewards was about trying to acknowledge and support and enable people to do that even better and to create calmer, safer wards. But we really appreciate all those people who've engaged with Safewards and helped us implement it. So there's Len presenting the results of that trial. So literally, I was working with him at the time at City University, and the trial was just coming to a finish round about, in the summer of 2013. And he was analysing the results with the statistician, and we had booked a slot in this conference for him to present the results. And he was genuinely very, very nervous because we did not know what the results would find. We just didn't know. He said, this may all be a flop, it might not work, and then what am I going to say? And we literally got the results a few days before the conference, and it was a big positive result where Safewards was shown in the trial, randomised controlled trial, cluster controlled trial, to reduce levels of conflict and containment, and I'll say more about that in a moment as well. But that trial was the culmination of 20 years of research led by Len Bowers and working with many, many colleagues. I was lying in bed last night thinking about this talk, and I was thinking, one of the things that Len was brilliant at doing was developing collaborations, working with other people. Many of you in this room will have had contact with Len. I met with a colleague, Heikki, from Finland this week, and he worked with Len on some work on different studies. And he was very good at linking with people, finding out what they were doing, working with them. And we ran all sorts of different studies, longitudinal studies, small qualitative studies, testing out little interventions, doing a big trial across England of 136 wards. And the whole purpose of that was to gain understanding and knowledge and testing out ideas with the view to how do we help improve nurses and wards to provide better care. And it ended up with the development of this theory-informed and research-informed intervention called Safewards. So it's a huge piece of work, reviewing loads and loads of literature, hundreds of literature reviews, loads of different studies that all came together with this Safewards intervention. And it's interesting because often all that work that's behind the scenes is not really known about. You don't really realise. If someone comes up with something and says, we're going to try this, you don't realise the length of time it's taken to get to that. I was lying in bed thinking last night, my first job was with Len when I started working with him. I worked with him for about 16, 17 years. My first job was going onto wards and getting patient records and going through them and recording all the incidents of conflict and containment against the definitions that we had. And I was literally going into wards. This was before everything was digitized on computers. I was going and pulling out cardboard boxes of patient files from under desks and wading through them and recording. It was very tedious work, but actually it led to us creating a measure, which was the patient conflict checklist, which we've used in multiple studies and I'm still using to this day. And we use that as a measure to measure the rates of conflict and containment on wards to see whether our interventions would have an impact on those. A big part of my job in Safewards was around the service user patient involvement and carer involvement in the development on testing of Safewards. So we created a group, we recruited 16 people to create a group of people with lived experience of having psychiatric care, of being in inpatient wards, or being a carer of someone a family carer of someone who'd been in inpatient wards, to work with us to test out our initial ideas, to look at possible interventions and give their feedback, talk about the ethics of the study, and so on and so forth. That group named itself called Service User and Carer Group Advising on Research, and they became known as SUGAR. We worked together for over 12 years in the end, and all throughout the trial period, the 5-year study, we worked together. And there's a picture of them, some of them in the room working together on some work with Karen James stood up there, one of the researchers on the study. We published a paper together in a psychiatric journal, and we went to conferences, presented at conferences, And I think sometimes, again, people don't recognize or realize how much input people with lived experience of mental illness and service use had into the development and testing of Safewards. So what do we mean by conflict and containment? Well, conflict are things like aggression and violence on our wards, rule breaking, substance and alcohol misuse, absconding, going missing from the wards, medication refusal, and people self-harming or attempting suicide. And containment are the measures that nurses and others on wards employ to try and either prevent, reduce, mitigate, or contain those conflict behaviours. And so it includes the use of occasional medication, coerced intramuscular medication, special observation, seclusion, manual restraint and time out. It's worth saying in the UK, up until very recently, we didn't use mechanical restraints. I know many countries do, but we tended to use manual restraints. That's beginning to change slightly, sadly, on some wards now. But those are those containment measures. And again, I'll say a little bit more about that in a moment. And then we had the Safewards model. So as I say, this Safewards model developed over many years by Len Bowers and colleagues. And it was built on that reviewing of a huge amount of evidence about conflict and containment across the world, and testing out different interventions. I worked on a big study of absconding, preventing absconding, and developing a nurse-led intervention to reduce absconding for wards. That fed into this. And there were many, many other examples of that. I'm going to pick up my piece of paper here because this is the one bit I want to make sure I get right. So we start off with the originating domains. By that, we mean categories or aspects of psychiatric wards as social and physical locations that are separate from the patient's normal residences, and they're there for the provision of 24/7 mental health care on a basis of a mixed voluntary and legal coercion. So in the UK, we have many people who are voluntarily inpatients, but increasingly a high proportion are coerced. They're in there under the restraints of mental health law. And in the UK now, something like 60, 70, even 80% of our inpatients are there against their will, which has a big impact on how we nurse people. And these originating domains affect to the degree they are present or absent and can influence the frequency of those conflict behaviours that I talked about and the containment measures. So then we talk about staff modifiers. These are the features of the staff as individuals or working as a team, or the ways in which staff act in managing the patients or their environment, initiating or responding to interactions with patients. And these staff modifiers have the capacity to influence the frequency of conflict and or containment. And an important finding in our work was that it's not a one-way direction of travel. It's not just that there is conflict and we intervene to try and contain. But very often, the well-intentioned measures that we employ to contain conflict leads to conflict. By imposing rules, by placing restrictions on people, it creates a dynamic that the person responds to. And the important bit of Safewards was understanding that our contribution, although we're often doing things for very, very good reasons, to keep people safe, to keep other people safe on the ward, to keep staff safe, very often the things that we employ can create tensions and difficulties and resentment and so on. And so it's understanding that dynamic and thinking about how do we as staff develop the way that we work, the way we communicate to patients and between ourselves, behind closed doors in the office. How do we talk to each other about patients, about what's going on the ward, in a way that reduces those potential conflicts? Patient modifiers are the ways in which patients respond and behave towards each other or with staff. And these have the capacity to influence the frequency of conflict and containment, and they are susceptible to staff influence. And then, crucially, flashpoints are the social and psychological situations that arise out of these features of the originating domains, signaling and preceding imminent conflict behaviours. So these flashpoints of potential areas when we can intervene. If we can anticipate or we can get in early, we can change the direction of behaviours and what's going on. So I've told you about what conflict means in containment, and this is the model on which the whole of the Safewards intervention is designed. So that we ended up in the work with the sugar group, the service user and carer group, and with other people, we pulled together a long list of possible interventions, many of them drawn from existing literature, many from our own work. And we were testing out with staff on wards, with service users and carers, things that they thought would be acceptable, that would be feasible to employ on wards. And we had a long list, and gradually over time, this got reduced to a list of 10 interventions, which were packaged up as the Safewards intervention. And these are those 10 interventions. I'm not going to describe each of them in detail. I will show you the link to the website. It's all there freely available, and you can look at all of them if you don't know these. But we're talking about clear mutual expectations. So having a community, understanding a therapeutic community on the ward, patients and staff together, and talking with each other about what do we expect from one another and how we are on the wards. How do we treat each other respectfully and humanely? And having mutual expectations of behaviours on the ward. And talking about those in community meetings. Mutual help meetings where we meet together with patients and talk about how may we help each other, and encouraging and supporting mutual or peer support on wards, which often happens organically, but helping nurture that to help people with each other. Talk down and soft words are encouraging staff to think about the de-escalation skills that they have and developing those, of the language that they use in talking with or about people to change the way we frame and see people, not problematizing them, but understanding them psychologically. Know each other, really lovely intervention where we encourage patients on the wards and most importantly staff on the wards to put up pictures of themselves and a little bit of information about themselves, about what their hobbies are, what their interests are. And the whole point of this is increasing that humanity, increasing that recognition that we are all people together, reducing those barriers, the us and them barriers between each other, and looking for points of common interest and common contact. Discharge messages, which I'll show you some examples of in a minute, is encouraging patients on the wards as they are approaching discharge to leave messages for new patients coming onto the ward. To give them information, thoughts, encouraging messages about their stay on the ward and how it can help in their recovery. And that's been very, very popular. Calm down methods. This is having a box or a cupboard somewhere where you have a number of items that people, it might be scents, it might be squeegee balls, it might be all sorts of different things, which people can ask for and use if they're feeling agitated to try and help them reduce any stress that's going on in the ward. And that's been, again, a very, very popular intervention. And wards have developed those in different ways. And some of the work we've done recently has found people using slightly different terminology to describe them. They don't like calm down, so they talked about, I forgot what they call them, but like relaxation methods or something. Positive words, again, is about encouraging staff to think about the labels and language we use about people. Bad news mitigation, being alert to and thinking about if someone's about to be given bad news or they have received bad news. For example, it may be difficulties at home. It may be that the psychiatrist has said they can't have leave that weekend and they were hoping to have leave. It might be that they were hoping to reduce their medication and the psychiatrist in charge has said, I'm afraid we don't think you're ready for that yet. So it's thinking about how is the person going to be feeling when they receive this news, anticipating it, stepping in, offering support, offering explanation, giving people a bit of time to talk through these things. Because we know some of the big reasons for people absconding, for example, or getting very agitated or angry, are those frustrating moments when they get this sort of news and how it makes them feel. And reassurance, which builds on what many, many good mental health nurses, psychologists and others do on our wards, is about how do we reassure people about what's going on and on their move to recovery. So those are the 10 interventions. There's lots of details on the website about all of them, their definitions, their explanations, and their mechanisms of change. So here's some photographs of some of the discharge messages that have been put up on different wards. And sorry, I'm just going to go back there. And as you can see, people embrace these in very, very different ways, with lots of imagination, lots of creativity. And one of the nice things about many of these interventions, not least this one and the Know Each Other, is that it encourages interaction. It encourages people to sit down together, work together, find interesting ways of creating these images and putting up the discharge messages. And it's whether you're working alongside occupational therapists, activities coordinators, psychology assistants, or the nurses, but sitting down together, working together, and developing these ways of promoting these messages. And people love this. They really engage with this and really value it. And we've seen many, many examples of them being done. We've done some work I'll say more about in a minute on children, young people's wards, implementing Safewards. And what we found there is on some of the wards, the young people were there for quite a long period of time. And we find this on some of the rehabilitation wards as well. People aren't swiftly discharged. They're there for many weeks, many months very often. And so people talked about having recovery messages. So rather than a discharge message, it was a message of recovery, of things that could help them in their recovery, giving people encouraging messages. And it's just, again, that part of creating a mutually supportive community. From the trial itself of Safewards, which culminated in 2013, there have been 4 papers published in research journals. There's the trial results, led by Len Bowers there, down in the bottom left-hand corner. There's the details about the model of conflict and containment on psychiatric wards. The details of the Safewards interventions and the empirical basis for the model. And a critical appraisal of the literature and the research that inform that model and some of the limitations of it. And a really nice paper, which was sort of a process evaluation that happened alongside the trial of looking at how the intervention was implemented on the wards. Where did it work well? Where did it not work so well? What were the facilitators and barriers? So part of implementation science, if you like, of considering that and looking at how do we measure fidelity and the strengths and limitations of the fidelity measure used in that intervention. So a real interesting package of papers which help you really think about how that trial was designed and delivered and evaluated. Since then, evidence for Safewards has been growing. People in numerous countries across the world have been implementing Safewards, testing it out in smaller or larger studies and publishing their results. And here are a couple of papers in the last few years talking about the implementation of Safewards and its impact on social climate on adolescent psychiatric wards. So interesting looking at the social climate. We often talk about ward atmosphere, and I know there are presentations during this conference about ward atmosphere and looking at that. And this other one, looking at violence prevention climate during the implementation of Safewards by Geoffrey Dickens, who's done some great work implementing Safewards in Australia and elsewhere. And here's just a list of some, not all, of the papers that have been coming out around Safewards. So you can see there's a real growing activity around researching Safewards and building that evidence base for us to understand where does it work, where are the limitations, what things do we need to adapt and change, and helping us think about improving this intervention. It's not a static thing which is going to stay the same forever. It's a growing thing, if you like. But there's a model that we should be building on in relation to that. And staggeringly, there are now 3 systematic reviews which have been published. 3 systematic reviews which have been published, summarizing those bodies of evidence. So the first one was by Finch et al. In 2021, and they reviewed 13 studies and concluded that Safewards generally has a positive effect and can help reduce conflict and containment in acute ward settings, whilst recognizing the need for more high-quality research. So some of the studies are more limited in their strength, and they're saying there's good evidence that Safewards works and has the impact we believe it does, but we need more research to strengthen that. Ward Stockham et al. In 2022 included 14 studies, and they evaluated the effectiveness, but they also looked at staff and service users' perceptions of Safewards and found that Safewards improved cohesion, improved therapeutic relationships, and improved ward atmosphere. What's not to like? Mullin et al. In 2022 conducted what was called an integrated literature review with the inpatients, acute inpatients, and forensic ward settings. And they included 19 papers, the biggest review so far. They concluded that Safewards can be effective in reducing conflict and containment within mental health and forensic mental health units, although the outcomes varied across the literature. This review also revealed the limitations of the fidelity measures being used, and I'll say more about that in a moment. The importance of involving staff in the implementation, which we've always thought was absolutely crucial. You cannot impose things on people. People get very defensive. If you walk in and say, you should be doing it like this, it feels like they're being attacked or you're being told they're not doing things right. You've got to work and engage with people and get their buy-in. We'll say more about that. And the need for greater involvement of the patient perspective. And most of my work these days, if not all of my work, is conducted alongside and involving people with lived experience of psychiatric services. We involve them as co-investigators, we employ people with lived experience as researchers, and we get their input into all of their work, all of the work that we're doing. And I think increasingly that's how we need to be developing our future research into Safewards, involving with people in lived experience in further research of that intervention. This is the Katie Finch review that I mentioned. It had quite a provocative title around, has enthusiasm exceeded the evidence? And in a moment, I'm going to explore that in a little bit more detail, because actually it was hitting on something. There was a huge amount of enthusiasm for the Safewards intervention, but sometimes people were rushing ahead slightly of the evidence. And it's important that we try and match those together as we progress. So let's cut to the chase. Enthusiasm for Safewards has been observed where it has been employed in a wide range of settings internationally. Whilst this review, the Finch review, indicates that there is good evidence to support its use in general mental health services, it is not yet possible to say that it is an effective model for reducing conflict and containment beyond this context. Further robust research is imperative in order to determine effectiveness in other clinical settings and to continue contributions to the model's growing evidence base. And in a moment, you'll see that there is a growing evidence base in other settings, but we need to do more. So overall, at the moment, there's a nice match between enthusiasm and evidence when we look at Safewards in general mental health wards, adult acute wards, in triage wards, and in psychiatric intensive care units, or PICUs as we call them in the UK. When we look at elsewhere, the enthusiasm is rather ahead of the evidence. So what happened between 2013 and the launch of the Safewards results from that randomized controlled trial and onwards? So, as I said before, the trial results were first announced at that conference in September 2013. In December 2013, the Safewards website, safewards.net, was launched. So all the materials were already prepared, the website was ready to go, and the moment we had the positive results, we got everything ready and we launched it in December that year. It went online and it outlined the model, all of the interventions, and extensive advice on implementation. There's advice for ward staff, there's advice for ward managers. The amount of information on that site is just incredible. If you haven't seen it, do have a look. It was made freely available. You didn't have to register, you didn't have to pay, there was no difficulties, you just click on it and you're in. So everything there, freely available. And this is Len Bowers. Len Bowers' commitment to improving what he likes to call psychiatric care, I call mental health care. It's absolutely, I will do anything I can to promote this and make this freely available to everybody. This really led to the use of the website and other social media platforms really help people who were interested and enthusiastic to have a go at implementing it. And in the UK, we have the National Institute for Health and Care Excellence, who have recommended the use of Safewards. And they said that one of the advantages, it needs little training, so there are few blocks to its implementation. So as well as the website, which you can see there on the left, there's a Facebook group. We've used Twitter, or X as it's now known. There are YouTube channels, which we've got training videos and all sorts of things. So Len Bowers ran those. Jeff Brennan runs most of those now, and I'm in charge of the website. So lots of information there. And it's helped create and grow a community across the world of people sharing ideas, sharing ways of working, talking about some of the difficulties faced, and problem solving together. It's been a fantastic community of people thinking about how do we work better. And it's led to people like Bridget Hamilton and a team in Australia, and Victoria in Australia, who've built a whole program of research across multiple wards in that state in Australia and done some fantastic work. So they did a big study on a range of different wards, adolescent wards, young people wards, adult wards, and I think some forensic wards, 18 wards altogether. And they managed, by implementing Safewards, to reduce the use of seclusion by 36%. And they also published a really fascinating paper looking at some of the barriers and facilitators to implementing Safewards on those wards. And they say that their findings suggest that implementation of Safewards to succeed, particular attention needs to be paid to the engagement of key staff, including managers, we agree, making training a priority for all ward staff, adequate planning of the process of implementation, and creating an environment on each inpatient unit that prioritizes and enables Safewards interventions to be undertaken by staff regularly. The Safewards website and all the materials have been translated now into 10 different languages. I'm not going to read them all out, but all of those countries there have been involved in implementing Safewards. The ones in yellow are where the materials have been translated into their main language. And most recently, Jeff and I were funded by the British Council to do some work with a colleague, Xia Huang, in Sichuan in China. And we've been training 108 nurses to date, mental health nurses in China online, to implement Safewards. And this month, Xia and her colleagues are going to start implementing Safewards on a number of inpatient wards in China, which is just absolutely fantastic. We're really, really excited about, and we'll be publishing on that in the next year or so. It's also spread beyond acute wards to secure units, low, medium and high, in CAMS units, child and adolescent mental health units, including under 13s, in older adults, in learning disabilities units, in emergency departments in Australia, and we're hoping to do similarly in the UK. We're having conversations at the minute. In eating disorders units, including children, young people wards for eating disorders, in children's homes, and in some general hospital settings. And we've just in the last month been approached by people in England in acute hospital wards asking about trying to implement Safewards. In secure units, Tess McGuire has been doing some fantastic work and conducted a Delphi study to look at what needs to be adapted to make Safewards absolutely applicable in secure units. And they've been doing some really fantastic work in Australia and elsewhere. And they found that Safewards is suitable for secure services, but are making recommendations for adaptations to be made. And that's been published in a paper in 2022. So if you're working a secure unit and you want to know more, we highly recommend this paper and look at some of the adaptations required. Our good colleague, Marcia, whose surname has gone out of my head, has been working with Broadmoor, which is the most secure psychiatric unit in the UK. And the Care Quality Commission, the people who go in and appraise the quality of our services, commended the use of Safewards in the secure unit and the huge impact it had on patients there and the reduction in containment methods on that unit. So as I mentioned before, Jeff and I were commissioned by National Health Service England to implement Safewards on 20 children and young people wards over an 18-month project. We've just finished that. And this is Nick, Marcia, Giselle, and Kath. So these were our project workers. They all had experience of implementing Safewards on adult wards. And they went out on 20 wards, 5 each, implementing Safewards with great effect. And we found it to be acceptable and useful on those wards. We've just had the paper published this week, so I'm very pleased it's there. Just came out on Monday. And people who are on the wards talking about the huge impact it's had. Again, creating interactions on the wards, young people really enthusiastic. They love the know each other stuff. They love the discharge messages and many other things. So in many ways, some of the interventions seem to suit children's units even better than they did the adult units. I'm just going to whiz through, I'm slightly going to go over time. So need for change, need for evidence. So where are we now? So for mental health acute inpatient care, the evidence is good in terms of reducing conflict and containment. And there's also some evidence to say that it improves therapeutic relationships, ward culture, ward atmosphere. For secure care, there is evidence, but it could do with being better quality and perhaps incorporating Safewards Secure from the Maguire's team. In other areas, there's undoubtedly acceptance of the Safewards interventions and even enthusiasm, but we need to ensure we have good quality evaluations being conducted to look at the fidelity to the model and the interventions, the adaptations required, and we really welcome people who publish papers describing adaptations made, and evidence of the effect and what things we are measuring the impact on. And although we have some evidence of acceptability from the patient community, we need to get much, much better at involving people with lived experience and getting the views of patients onwards about Safewards. I mentioned fidelity. We're working with Anna Borkdahl and other colleagues who've been very influential in implementing Safewards across Scandinavia and Europe, and we are refining and developing a new fidelity measure. Anna's leading on that work. Jeff and I and others are involved in that. There's been a big Delphi consensus exercise underway. It's nearing completion, and soon we'll be testing that out, piloting that on some wards. And we hope that will be a useful measure for researchers and people implementing Safewards in the future. Nearly finally, absolutely essential we get the patient view much more involved in developing Safewards. So, Safewards has come a long way in the last decade, probably far further than we ever hoped or imagined. So let's celebrate that. In the UK, this has been in the face of major difficulties. We've got unbelievable underfunding of our mental health services, huge staff shortages, huge staff leaving services, lots of change while we're trying to implement change, makes it very, very difficult to sustain change. The evidence is generally good, but there have been no reported harms. We do need to adapt the model for settings beyond acute care and to build that evidence base. I think that's it. And we look forward to the next 10 or so years. Thank you very much for listening.